season of the Breech Birth podcast will be a little different. I'll be speaking with researchers, midwives, and obstetricians working within the breech birth space, bringing additional perspectives, knowledge, and evidence-based research to you, the listener. I hope you enjoy these conversations. Hello, Dr. Firas Cha'ban. Welcome to the podcast.
Thank you.
Before we jump into the questions that I have for you, would you mind sharing a little bit about your background and your experience around breech and twins?
Well, I'm almost 30 years of an obstetrician now and getting old. And already from the first instance that I was assistant in training, contacted one of my teachers, did breech deliveries on the most classical way there is. And so my first contact was, I think I was around 26, 27 years of age, and I was already interested in that situation. Of course, as you know, breaches are not that frequent. So along the history, regular basis, we did a breach, but not so frequently as I wanted and as it is. And bit by bit, it remained the same. You know, this was the year 97, what I'm talking about. So in the year 2000, a trial appeared, and then after that, everybody stopped doing breaches. So this was for us not a real problem because we continued more or less the same thing as we did. So in strict indications, when patients really wanted it, and there was not kind of a real protocol. In fact, we worked with materials that were handed out at that time, but there was no strict protocol. So what we did was like 5 or 6 breaches in a year time. So not so many. And yeah, I know everybody stopped doing breaches the last 25 years. So we had a 90% C-section rate. So from time to time, it was even a big risk to do breech deliveries. People considered you crazy and considered you taking big risks. The next interesting period was in 2000, I think it was 2018 or 19. And there I heard speak of Professor Frank Lauwen, who is from Germany, and he has a very big breech database, which is called Frabat, and it's very interesting because he started doing breaches on a totally different way, and that's where I first met the upright breech delivery and the physiological breech delivery. So I contacted him, and I went to his center for 2 weeks to see how they work, what the protocol was, how they did it. And I brought that knowledge to our center. So from 2020, just the COVID year, we started with a breech center in our hospital. First, I talked to all my colleagues about it, started up. We are now in October, we will be with 9 people. At that time, we were with 7 gynecologists, obstetricians. So I proposed them to start a breech center. I wrote a protocol with the knowledge I had from Germany. And we started a breech center bit by bit. Then a few years later, I think now 3 years ago, I all of a sudden I met Breech Without Borders, and I met Dr Firas. Immediately, I was fascinated by their work and their methods of working with breech deliveries. So I did the course, first the online course and then the hands-on course. I went to Barcelona, I met Christine, I met Rixa. And I think their way of working with breeches is absolutely perfect. So now we do in our center, and happily I trained almost 8 of the 9 are trained now by Breech Without Borders. So all my obstetricians did the course. So we all do the same thing. And we have a protocol approach of breaches. My next step I became also trainer in Breech Without Borders. I'm one of the many trainers. My next goal is to implementate the whole system of Breech Without Borders for all the obstetricians in the Flanders. And a few months ago, we had the big hospital in Ghent, in which we trained 32 gynecologists. In the next few months, in November or December, I'm doing again 2 trainings in Belgium. So bit by bit, it's like a web getting bigger and trying to convince people that's the real system. Because, I think what we did until now and this is very important. This is some kind of vision I have. We did until now, and the whole literature, probably the literature about breech is very negative. Everything about breech is negative. And well, that's correct, because the last 100 years or more, everybody did the same thing: breech on the back and pulling out the baby as quickly as not as quickly as possible, by a certain rhythm, by a certain way of working. Well, if you change that whole system and you use the new system of working with breech, upright, a specific timing of delivery, specific vision of the baby, a specific follow-up of the mother and what she does, etc., I expect to have better figures. But we need to prove that to convince the medical world.
Yes, the slow path. Very grateful for doctors like yourself that are trying to make that change. It's a hard job, but it's
Doing
needed.
my
So
best.
thank you. Yeah.
Unfortunately, I started this too old. I needed to start this when I was 20.
Well, you're already doing it, training the doctors working with you, so that's a good start, and they can continue
Absolutely.
that path. Yeah, beautiful. Thank you. You have a wealth of knowledge. So, our first question that I've got for you is, off the top of your head, if you had to take a guess, how many breech singleton births have you attended?
I think somewhere between 400 and 500 breech deliveries.
So quite a lot. Yeah.
Well, in the breech world, yes.
Yes. And do you do twin or triplet births?
Yes, we do twin birth. Triplets, to be honest, the last triplets I had, I think it was 20 years ago. So there are 3 girls the age of 20 now.
Oh, wow.
It's rare to have triplets in Belgium.
So how many twins do you think you've attended for birth?
It's very difficult to say, but I like more or less, I have like 10 twins a year. So, yeah, probably 150, something like that. 200.
Beautiful. Awesome. Thank you. What's the most common breech presentation that you have witnessed in your own practice?
The Frank breech.
Frank? Yeah. And what is the most unusual situation that you have witnessed at a breech birth, looking back over all the years?
Well, this was a few weeks ago. I was on duty in the hospital, and all of a sudden I got a phone from a midwife, which was at home, an independent midwife. And she called me that she had a woman with a 4th child starting labor, and that she felt it was a breech, unexpected breech. So I said, okay, it's a 4th child, come to the hospital, we'll manage this. This woman had 3 easy deliveries at home, 3 times, no problems, normal weight, 7-pounders, 7.5-pounders, nothing really special. This labor, so I didn't expect any problems, and these are the ones which you have to care about and which you have to think in the back of your head. When you don't expect any problems, problems arise. And watch out with 4 children, which everybody thinks, oh, this will fall out. Well, she went in very slow labor, which was already something that annoyed me. But of course, the more children you have, the slower sometimes labor goes. Okay, I gave her time. Finally, she reached like 10 centimeters of dilatation. There was no epidural, so it was a standing up, squatting, standing up, laying down, doing every kind of position. She had a lot of freedom of movement. And at a certain time, she started pushing. And what we have in our hospital, and this is, of course, not available everywhere, that's an internal monitoring. So we put an electrode on the butt of the baby. And this gives and will give in the future, I hope, insights about how the baby's feeling and how the baby's doing during a very important time when it's in the vagina. You can't hear the heartbeat anymore outside. So you need to make decisions. Everything went well. The pushing was not what I expected. It was a very slow pushing. For the first child, you would expect women to push 3 times and to have a baby. This is my naive instinct, but not the case. It's a very slow pushing. And at a certain time, the baby crashed. So it had a heartbeat of 50 without recuperation. So it stayed very low. And then the baby was at the entrance, at the introitus. So we didn't have any choice. So I put her on the back and we did the fundal pressure to push the baby out. And then it came out. So when the baby comes out, this is something I do frequently, depending on how women push. So they can have freedom of pushing how they want. But if they don't push well, or there is something that I need to speed up, I put them on the back and we push with them on the fundus. This is something we have from the head deliveries previously, which is not done anymore now for head deliveries. And once the part of the baby is born, I turn them around on hands and knees, so upright. And then this woman was turned around, and this baby was total posterior position. So baby's back looked at me instead of baby's thorax. So this was a posterior breech, which is very rare. And this was the first time I met one. And we had to deal with it. I think I did some 4 maneuvers to turn the baby around.
Did you do
Rotation.
prayer hands?
Yeah. Rotation
Yep.
maneuvers. Partly, I got him more or less 90 degrees. It wasn't turning easy. So both arms were really stuck like this. And then I released the arms. Then I got him right. Then the head was again a little bit sideways, which I needed to fix also. And then we did thoracic pressure. And then we got the baby out. It was a good baby. We had a low Apgar, but the pH was perfect. So, and the whole maneuver thing, we did in 1.5 minutes, so very quick, and that's the advantage of seeing what happens before the baby is born and having that monitor.
Yeah.
So this was
Oh, great. Breech Without Borders will love that. So I have had a posterior one as well. And I just did a review on that with the Breech Without Borders on their lives. I know how it feels to get one of them.
yeah.
Awesome. Thank you for sharing that story. Next question I have is from one of our listeners. What does the research say about the risks with vaginal breech birth versus vaginal head down birth versus breech C-section in a nutshell?
Well, strictly seen, if you follow up the old literature, then we have a risk of C-section is 1 in 2,000 of dying during the C-section for the baby. The vaginal delivery is 1 in thousands, and the breech delivery is 1 in 500. So this is the old literature. These are the old figures we need to tell everybody, and which my hair on my hand goes up when I have to tell those figures, because in fact, what you tell people is that the risk of dying is like 4 times bigger when you do a breech delivery than when you do a C-section, which is not correct. But these are not absolute risks, of course.
Yeah. Perfect. Thank you. Another question from a listener. How would you navigate cord prolapse during the pushing phase of a breech baby?
Well, we had one woman which had a bad monitoring registration during delivery, and we had, by examining her, we felt that there was a cord down there. So the midwife had the nice idea by pushing the cord back. So when she did that, the monitoring got better immediately. And this is in fact my only experience with cord. You know that at Breech Without Borders we are considering a cord prolapse, depending on the situation, of course, not as urgent as with a head position, because in breech the cord is less blocked and less obstructed by the position of the baby. There are situations in which even with a cord prolapse you can have a breech delivery. So everything depends on the situation. The prim, quick is it? What is the exact position? What is happening? How is the monitoring? How is the baby doing, etc., etc. So there are a lot of things to consider.
Yeah, looking at the whole picture.
Of course.
Another question from our listeners. When are maneuvers required during breech births?
Well, that's the interesting thing. I think very probably what's the figure? Around 80% or maybe more of the breeches are normal deliveries. So you look at them with your hands crossed, you stay off them, and you support the woman. That's the most important thing. So most of the times we don't do anything, but there is a difference between doing maneuvers. This is new. This is something I see nowadays. There is a difference between doing maneuvers and stimulating the patient to push. So
Yeah.
this is not a maneuver, but it's kind of an active management of breech. And this is something new, and this is something we need to do more and more. I hope as less as possible maneuvers. And the thing is, first you have to see what's happening. Is it a normal process of delivery or no? Do we have a baby which is looking at you? Do we have a baby which is sideways? Do we have a baby which is backwards? This is the first thing. The second thing, and those things you have to do, you see both together. Second thing is, how is the baby doing? If I don't have a monitoring, which we have, if I don't have a monitoring, what does the baby look like? Is it pale? Is it hanging there? Is there tonus? Is there gasping? What is he doing, this baby? So this gives them an idea. And so combining both, you know what to do. Do I need a maneuver? Yes or no? Do I need to speed up this situation? Theoretically, and this is something difficult because it's very difficult to talk about timings, you know? OptiBreech from Sean Walker. OptiBreech talks about several minutes, etc. And that's not bad, but it's sometimes annoying and dangerous to work with strict timings. What I do for myself when the baby is born, the butt is born, the bitral canter is born. This is what we call the white line of the baby. So what I do for myself internally is give myself 5 minutes to have a baby after this white line. Why? Because we think that when you wait longer, the chances of asphyxia, hypoxia are much bigger and damage. So I want this baby out within the 5 minutes after the white line is born. And then it depends if she's a good pusher, if she feels it, if everything goes well, why should I do anything? I have movies of that. People having a first child without epidural, pushing it out in one stroke, one contraction. It's fantastic. And then some women can't push. A lot of my patients have epidurals because we do a lot of twin breech deliveries. And so we're going to have epidurals. And even if we do walking epidurals, they have a loss of sense anywhere. They don't feel the situation well. So this makes it a difference. And this makes this process totally different. And that's the only important thing to keep in mind. So what is happening by itself? Is it going on or not? Do we expect to do a maneuver? Yes or no? What is the baby doing? If the baby is okay, we have time. But of course, it's not because we have 5 minutes, you need to wait 5 minutes. Depends again on the situation and how is the baby responsible.
Yeah, perfect. You mentioned before about the encouragement of active pushing. Could you just explain to our listeners why there's encouragement for active pushing in a breech birth?
Well, because the thing is that what we are used to doing, and especially this is for midwives very important because we see this a lot with midwives, which are great helpers of deliveries, of course, even before doctors were there. We are used to giving people time. And when you have a head delivery, we don't force people. Take your time. Everything is okay. The baby is okay. With breech, we have two different things. First, you don't know if the baby is okay a lot of times. Hearing the heartbeats with a dub tone is not so easy when the breech is very low down. Second, when a part of the baby is born, the fundus is an empty sac and doesn't contract well. So what happens is that if, like the classical way, let's wait for the next contraction, that doesn't work for breech. So we don't wait for the next contraction. When this part is out, like I said, I give myself five minutes. I'm active. Come on, push again. Take air and start pushing again. And again, take air and start pushing again. So I don't wait for the contractions because sometimes it takes like 10 minutes before the next contraction comes, and then you lost 10 minutes. And then you see that the baby's in troubles. And then you start pulling on a baby and doing great bad things.
That's perfect explanation. Thank you. Another question from a listener. What are the optimal birthing positions for birthing a breech baby and why?
Well, I don't think there are optimal birthing positions. You know, the optimal position is the position in which you as a woman, as a mother, feels good. It's not the helper that needs an optimal position. It's you that needs an optimal position. The only thing is that, of course, I want to help you. And so you have to let me help you. And some positions don't allow me to help you. So, I have a question a lot. Can I have a breech delivery in bath? I say, no, I'm sorry, because I can't join you in that bath. And I have to put on my swimming trousers and dive in the bath to get the baby out. What's the idea? So you can have your labor in bath and come out of the bath to have the baby. And the most frequent positions I do is on the back, supine, on the stool, birth stool. And, I'm testing out a lot of new positions because I didn't find the right hospital bed for a breech delivery. I think a good interesting thing is to have a mat on which you can use a ball, which you can use a birth stool, so they can change positions all the time. Find out for yourself what your good position is. But when when you help a woman with breech, make it yourself as comfortable as possible to help her.
Great. All right. So this is an unusual question that was put to me from a listener who was told this by a doctor. Is it true that breech babies don't fill up the uterus and therefore there is no lower segment?
And there is no lower segment. What? She mean by that there is no lower segment?
Exactly what. So this is something a woman was told by the doctor, is that a breech baby doesn't fill the uterus and therefore it doesn't grow the same. And so they don't have a lower segment, like it hasn't expanded up, which I didn't believe.
So what I think, there is the uterus segment doesn't change by the position of the baby, of course. So what that has to do with the position, I don't know.
Yeah, no, I guess it was probably a fear.
Yeah.
It would have just been a fear-based statement to scare a woman into having a cesarean,
Yeah.
no doubt.
That's one of the big problems that doctors have. If they don't know it, they start inventing things and fantasizing things and telling people what is dangerous and not. And that's a problem sometimes. If you don't know, you don't know. Tell the people that you don't know and
Yeah,
then
exactly.
guide them to somebody who knows.
Yeah. If you had to share top tips to parents on the research around breech, what would they be?
Well, that's a problem nowadays. That's a big problem because the whole of the literature, when you look at databases on internet at this point, is based on everything past 50 years with breech, past 100 years with breech. So I did a small analysis not so long ago for a talk, and even at the time of the Romans or the Greeks, early ancient times, breech was something considered as abnormal. So, like I said, most of the literature says it's bad, it's dangerous, don't do it. And the new ideas about breech, which already started a few years after Hannah, the study of Goffinet, the big Belgian France study, Premoda, which already told the opposite of Hannah. This was a very large study, a very good study, and it already proved that if you have the right criteria, breech shouldn't be that dangerous everybody considers. Now, since 2016, we have Frank Lauwen's group, and his database is now more than 2,000 breech deliveries in more than 10 years, which is great. Fortunately, it's a single center database. So it's not considered by everybody as reliable enough because it's single center. So you need to do this in a lot of centers to prove that it's okay. So that's the goal we have with Breech Without Borders, is everybody starting to do it the way we teach it. And we hope that then in the future we'll have new databases and new studies about how breech can be done and that breech can be safe.
Yeah, great. We're working on it. A question from a listener. Are you still likely to progress if baby's foot is presenting in front of their bottom?
Progress in the meanwhile having a delivery, you mean?
Yes, yes.
Yeah, yes, of course. This is also a very interesting discussion I have with a lot of my Belgian colleagues here in Belgium, is what is a foot delivery? What is a footling? What is a foot position? And in most of the guidelines in the world, footling is a contraindication for breech deliveries. But in fact, the discussion I have with my colleagues is there is no such thing as a footling position. That's impossible, because first, the baby can't stand up in the uterus. This is a true footling position, with the feet first, like this. That's impossible. And then second, when you look at all the deliveries I've done, when you have a foot position, when the baby is transverse, then you have a foot position. And then with a transverse position, it's not possible to have a normal delivery. But all the other cases are foot with butt or 2 feet with butt, etc. So that doesn't matter for us. We have the deliveries, even if a foot is presenting. But the labor can be different, and sometimes the delivery can be totally different. So it's not always the easiest breech delivery, because baby can malpresent that way.
Great. So you've kind of mentioned some of the research already. One of the questions from the listeners: what recognized resources can I share with my health team to help make informed choices? So just to simplify, what would be the top 3 research recommendations?
Well, I wouldn't do Hannah anymore, so I would cancel Hannah, maybe just to tell the history and the evolution of the breech. So I talk about Hannah to my patients because I explain why nobody does breeches anymore. So this is the only way to talk about Hannah. And then Goffinet, the Premoda study, this is one study which is very interesting to talk about. And the Frabat database. And there are like 10 or 20 studies coming out from the database of Frabat. This is the Frank Lauwen, the German group. Those are the 2 biggest studies which are not negative about breech.
Great. Perfect. Thank you. Why do you think breech vaginal birth is feared or avoided by obstetricians?
Because, when your whole career and your whole training, you always hear that it's dangerous and that babies die from it. Yeah, well, you don't do it then. And the thing is, the biggest fear of everybody is the head, which will get stuck. And that everybody knows a history about a stuck head. That's very typical, you know? It's one baby and there are 20 stories about that same baby. And everybody's afraid of that. But strictly theoretically, if you keep your criteria well, so there are no preterm breaches, for example, no growth retarded breaches, these are excluded, well, then a butt and legs are bigger than a head. So if that comes out, the head comes out. And then the problem is that nobody's trained in breech, so nobody knows what to do when a head doesn't come out easily or arms are stuck. And then they start pulling. And this is something, it's a nice image I saw on one of the talks of the thing that is the, how do you call it, in the kitchen. It is blocked.
The stuck drawer.
Yeah, the stuck drawer.
Yeah.
Yeah. You start pulling it, it doesn't work. And then, you know, you have to release what is stuck before you get it out. And this is exactly what we do with breech.
I think that stuck drawer has really helped a lot of practitioners. I think you're the second or third person I've interviewed that's mentioned that. And because I teach breech as well, I've had a few midwives that have done Breech Without Borders, and that's really stuck in their head and made them go, yes, that makes sense. You've got to disimpact to make space. Yeah. Perfect. Last question. Can you tell us about the new breech era?
Yeah. Well, that's something we're doing now. This is, I hope and I think we're getting somewhere. You know, there are two things. First, we need to convince people that what we're doing with Breech Without Borders, I mean, that that's a good system that works. And of course, it has to be acknowledged by figures. So where first we need to teach a lot of people of that system. Everybody has to start doing it, and then we have to see the results. And what I hope is if everybody does this system, and if it's done correctly, of course, then the results should be better. Like we started this talk in the beginning, there is another way of thinking about deliveries, another way of management of breech deliveries. So I'm 100% convinced that in the future, those figures will get better if we start doing other things with breech. And this is very important also for the midwives because, you know, I've worked more than 20 years with midwives, independent and hospital midwives, so I know them. I learned a lot of things from midwives, so all my respect. But sometimes they are too conservative, and don't be too conservative with breech. Watch out. If you're doing a breech at home, which I don't advise, but if you don't have any other possibilities, watch out. Know your stuff.
Yeah. Be prepared to be hands-on.
Without water. Yeah. Be hands-on and manage the breech.
Is there any last words of wisdom or advice that you'd like to tell our listeners?
Oh, I think, you know, we have to stimulate this because first, everybody's very conservative. When there is no knowledge and there is a lot of fear, nobody wants to do anything and nobody wants to do new things. So I consider myself a little bit of a pioneer, but there are already people before me that started doing things. But, you know, I want to push this down. I want to stimulate this. So the more we give those teachings and lessons, the more people start doing the same thing as us. I hope that we can all work together in having nice figures in the future and changing the idea about breech. So I hope in 20 years when a young gynecologist, obstetrician or midwife starts, they can say, you know, breeches is one of the things we do, no problem. But it'll take a lot of time. So
We have patience.
we have to have patience.
Amazing. That's all I've got for you. So thank you so much for your time.
No problem.
Appreciate all your wisdom.
If we can share it, if we can do something with it, great.
Yeah. The Breech Birth podcast is independently created and produced. If you'd like to support the continuation of this space, you can do so through Buy Me a Coffee. Your support helps keep these stories being shared and accessible to women and families around the world, and you can find the link in the show notes. Thank you for listening to the Breech Birth podcast. These stories matter. They stretch what we think we know and bring voice to experiences that need to be heard. I'm so grateful to our guests who have shared their experiences with us, raw, real, and full of wisdom. If this episode resonated with you, please subscribe and share with others. You can find us on Instagram, Facebook, and YouTube at Breech Birth Podcast. And if you have a breech story to share, I'd love to hear from you. Until next time, may we continue to reclaim the narrative, one story at a time.